need to sign in to YouTube in order to be able to leave comments and questions. So if you can do that, do that. And if you are unable to do that, then you can write to our conference people, and they'll get your questions, and we'll address those at the end. So we'll just start in just a few minutes. Good morning, or good afternoon, or good evening, wherever you are joining us in the world. This is the CCIH conference session on mapping of faith-based health systems. We're going to start in just a few minutes, so we can give people time to join from wherever they are in case they're having any technical problems. You can see that we're live on YouTube. You should be able to enter your questions that you have for our speakers. We will cover these at the end of the seminar, but you can go ahead and type them into the Q&A box at the bottom of the screen. You do have to be signed on with a username at YouTube. That's free to do, but it can take some time. If you can't do that, or you don't want to do that, you can also send your questions to the email that's on the slide here, webinar@ccih.org, and we'll add your questions to our queue, and hopefully have time to address most of your questions, probably not all of them. But we're just going to give a couple more minutes for others to join us. We see people joining us from around the globe. We've got people from India, Uganda, Haiti, the US, even the US is here. We're going to start at 8:03 Mountain Time, 10:03 Eastern Time. I'll let you do the math for where you are. Great. Welcome. You've joined a CCIH conference session on the mapping of faith-based health systems. Once again, you need to be signed in on YouTube in order to be able to ask questions, but we welcome questions from the audience, and we will cover all of the questions after our three speakers have spoken. And if you're unable to get your questions through YouTube, you can write at this address that's on the screen right now, webinar.ccih.org, and we'll try and address all of those questions. For those of you who are new to CCIH or who have not come to an annual conference in the past, this is like most things these days, is the first time having a virtual conference for this big conference. And I would encourage you to from this point on, join every year, because it's a terrific conference. And the CCIH people who have done a great job really translating this conference into 6 weeks of topic-based webinars. So hopefully those also have been helpful. If you have not joined any of those yet, look at the website, and you can join ones that are of your interest. You might know that CCIH is an international network of Christian organizations involved in healthcare. We have about 115 organizations, Christian organizations, with about 15 secular partners and hundreds of individual members. And it's an opportunity to really come together and talk about what God is doing around the globe from a Christian perspective in capacity building and best practices and advocacy and issues related to health. Each of our sessions is sponsored. We have sponsors who help us with some of the costs of this, and we also want to highlight them for the important work that they're doing in global health. Our platinum sponsor from today is Abbott, and I'd like to introduce Stuart Knight from Abbott Pharmaceutical. They're a platinum sponsor. Mr. Knight is a vice president for global accounts, infectious diseases, emerging markets, and Abbott Rapid Diagnostics. So welcome, Stuart. I'll just give you a few minutes just to share.
Great, thank you, Perry. And greetings, everyone. So I am Stuart Knight, and I represent the Infectious Disease Rapid Diagnostics Division of Abbott. And I'm very pleased to convey how happy we are to sponsor this year's CCIH annual meeting. Abbott is committed to improving patient outcomes by offering healthcare professionals and their patients with access to high quality, affordable, infectious disease point of care diagnostics designed for any care setting, whether this care is delivered in a large hospital in a capital city or in the most rural corner of a country. Access to accurate tests and quality treatments is critical to these patients as well as frontline health workers. Throughout low and middle income country regions, Abbott's diagnostic tests are used every day to empower patients to better understand their health status across a number of disease areas, including HIV, malaria, hepatitis, a large number of neglected tropical diseases, and now, of course, COVID. Providing patients with access to quality tests and treat solutions is key to making disease elimination a reality for many diseases such as HCV and malaria, while tackling opportunistic and devastating diseases like cholera, which are so deadly to vulnerable populations, and particularly devastating for children under 5. Abbott is proud to already call many CCIH member organizations partners today as we tackle some of the most serious health threats affecting the most vulnerable populations we serve collectively. I look forward to gathering additional insights from many of the organizations on this call as we engage in a deeper dive into how we can work together to meet the challenge of health system strengthening. Thank you.
Thank you, Stuart. Appreciate that. Our other sponsor for today, our gold sponsor, is Cure International. Many of you know Cure International. They are an international mission seeking to heal the sick and proclaim the kingdom of God. They're currently operating in 14 different countries through charitable hospitals where patients experience a life-changing message of God's love for them. Cure specializes in providing surgery to children to treat conditions such as clubfoot and other disabilities. And we want to thank Cure for their sponsorship and encourage you to go check out their website and learn more about Cure. So today's seminar is going to be on mapping of faith-based organizations. We do want to encourage you to ask any of our speakers and CCIH any questions that you may have. As I said, you can type those in the bottom under the question and answer little box, and those will go directly to our facilitator and then to me, and we'll hope to get to as many of those questions as we can. If you're having trouble putting the questions into YouTube, you can send your questions again to webinar@CCIH, and we'll try and get those added to the list. This video will be added to the website actually in a few hours. And so if you've missed this, well, you wouldn't be on here now if you haven't missed it, but if you want to recommend it to others, they can also watch it later. I'm Perry Jansen. I'm a family doctor, currently living in Idaho, but I spent 16 years working in Malawi, primarily focused on HIV, and led an organization called Partners in Hope. And it was during that time, really, I got a strong interest in health system strengthening and the importance of it. Since returning, I'm working with African Mission Healthcare. It's also a 501c3 that is providing support for mission hospitals really throughout Africa. And I'm very pleased to be leading this session because Mwai and Barbara are people that I work with on the health system strengthening group of CCIH, and they're doing great work across the globe. I want to introduce our first speaker. Our first speaker is Barbara Campbell. She's a pharmacist in Minnesota, has worked in pharmacy operations for over 20 years. In 2010, she was following the Lord's direction. She made a big career change and began working in Haiti as a director of medical operations for a large mission organization. In 2017, Barbara joined the Dalton Foundation as executive director and program lead for Relink Global Health. She's a co-chair of the CCIH Health System Strengthening Working Group. Barbara, welcome. We're excited to hear from you. Turn this over to you.
Thank you, Perry. It's really great to be here today, and welcome to everybody joining us. I'm thrilled to be here to share with you some of the mapping work that we've been doing. Today, I'm going to feature some of the work that we've been working on in Haiti. Kathy, you can go to the next slide. Before I start, I just want to go into a brief overview of what we do at the Dalton Foundation. We do a lot of work on international healthcare projects. We also do a lot here locally with in the US with addiction recovery and reentry and workforce development. But no matter what we're doing, we have a three-step process that's outlined here. The first thing we always do is some type of data mapping or understanding the marketplace or landscape of where we're going to work. And we just think it's so important to understand who's doing what and where before we go in and invest. The second thing that we always do is get involved in education and collaboration in some form or fashion. We always join the CCIHs where we're working, or the Christian health associations. And if we find ourselves in a place where one doesn't exist, we help form it, which is one of the things we've helped do in Haiti with the Haiti Health Network. And then the last thing that we do after we do the mapping and the education and collaboration, we sit down with everything we've learned and all of our stakeholders, and we design strategic projects for a given region. So Kathy, you can go to the next slide. So why do we do mapping, and why do we think it's so important? Today, I'm going to go through why we do mapping, how we do mapping, and then what we do with it. And so the why I've shared a little bit already. It's really just to identify the areas of greatest need, to make sure that we are not overlapping any work that's already being done. It really helps us to identify strategic partners. We do share all of our data with government and other decision makers so that they can utilize it as well. And then another thing that we're really passionate about too is sharing our data, at least some of it, publicly. I'll share that in a minute, how we do that, but we want public to have access to it to improve access to care. We also, I'll show this real quick, we also print our data. So in areas where technology is lacking, we print any of our data so that people can have resource guides. And then the last thing, as I said earlier, what we do with our mapping information is use it to design strategic programs. So Kathy, you can go on to the next slide. I'm going to go over briefly kind of our project in Haiti and kind of our process and our approach to how we did it. Our data collection process, I divided into two different phases for how we worked. The first phase is completed in all 10 departments in Haiti. And that was a data aggregation process where we took a lot of existing data from various sources. So the Ministry of Health was the first and obvious largest source of data. And then we brought in a lot of the NGOs that are not under the Ministry of Health umbrella. We basically went to any group we found that was collaborating and got their black book of information. Our staff verified it and vetted it and entered it into the database, which I'll share with you in a moment. The second phase that we're working on, and we're complete in 3 of the 10 departments in Haiti right now. This is a detailed capacity gathering process where our staff goes to each and every facility under the direction of the Ministry of Health and is collecting capacity data, everything on staffing, electricity status, access to essential medications, access to equipment. All these kind of questions are being asked in this level of collection. And in order to collect all the data, analyze the data, and use the data, we've developed the tool, the Relink Global Health tool. So Kathy, you can go to the next slide. Just gonna really quick kind of sort of not live demo this for you real quick. If in this first couple of things I'm gonna show you are what you would see the public facing side if you were to log on to relinkglobalhealth.org, this is what people will see. And this example is Haiti. The software is designed to be used in any country and adapted to many different contexts around the world in multiple language. This particular thing I'll show today is in French, English, and in Creole because it's focused on Haiti. But it shows all the different categories of services from emergency care, specialty services. We have about 31 specialty services we categorize, primary care services, dental, vision, mobile clinics, basic clinic, lab, pharmacy. We also categorize diagnostic image. Where can you find an x-ray machine in Haiti? Where can you find ultrasound machines? We do a lot with the special needs as well. We categorize for visually impaired, hearing impaired, physical therapy, occupational therapy, prosthetics. And then our last 2 categories focus on supply chain for where can you find and procure medical equipment, where can you find medications and supplies. So just to show you a little deeper into the database, if for example, I was going to click on specialty services, 31 options would come up. And for this demo, I just selected cardiology as one of them. And then the screen that on the right is what you would see, and it would continue to scroll down if this was live. But then you can sort by different organization types. For this particular project, we're mapping the entire healthcare system in Haiti. So we're doing government, the non-faith-based NGOs, the faith-based NGOs, and also we really wanted to include the private pay, private practice physicians as well. Then you can go and further select by the department. And then after that, you can further narrow it down to the village that you wanted to search by. So you can narrow down your search. So just real quick to go through this example, if we were going to click on one of the faith-based organizations, which is represented by that icon in red with the cross and the hands, you would click on like Hôpital Sacré Cœur and below. Kathy, you can switch the slides. Then you get to the detailed information about the organization. It will map their specific location. It has their phone number. I will mention this is adapted and works on smartphones as well. If you are on your smartphone and you are in Haiti, it would directly dial the facility for you. It has email, it has website, and then it lists all their services. So it's basically just a directory for people to have access to. And go on to the next slide. Kathy. And that's basically what the public will see. And then we've got some features on the back end that help us manage and organize our data. The first thing is we do have a provider portal where organizations can sign up, get an email, password, and then once they're vetted and verified, can update and manage their data. So this helps us keep our data up to date. We still have to do any other things, but this helps. And we do have hundreds of organizations in Haiti that are doing this right now. And then the screen on the right real quickly just shows you what our staff would see, just a snippet of it. It's color coded on the back end in green, orange, and blue. Any data in green and orange gets displayed to the public, and any data in blue is our detailed capacity data that does not get displayed publicly, but is used for our report generating in the work that we're doing. So Kathy, go on to the next slide. So what do we learn from all this data from our Haiti project? I could put up pages and pages of data, but I just wanted to summarize a few things for you. One of the things that we learned that did surprise us a little bit was the lack of basic diagnostic equipment in the rural clinics. Everything from otoscopes, ophthalmoscopes, glucometers, blood pressure machines, a very lack of them, which was really concerning to us because it really hindered providers' ability to provide that care close to home for the patients. We also noticed, but weren't terribly surprised by the fact that there was not a lot of biomedical training, people to maintain equipment. We did see a lot of broken equipment, which again, we all know makes it harder for physicians to diagnose and do their jobs and affects patient care directly. Again, we learned a few other things about non-communicable diseases and the medications that were available to treat them. Quite a few organizations didn't have many things available. We noticed leadership, lack of training, and actually an absence of it in a lot of clinics, which was something that we're looking to address. We learned too, and not terribly surprising, that electricity is a huge factor. No facility, excuse me, had 24/7 electricity. They all had solar power, inverters and generators to deal with, so it's a big thing when designing projects. And then we did also notice that many facilities are very understaffed. And this obviously directly affects patient care as well, especially in the rural areas. We saw a lot of clinics that just had physicians and didn't have full-time physician on staff. So I know I'm about out of time, and I just wanted to share just this would be a whole nother talk, but some of the actual conclusions from this and some of the things that's led to that we're working on some practical results. To address that first issue we really noticed with the diagnostic clinic, we gathered some partners and we've been working to assemble kits that contain all this equipment. We call this the Equipping the Caregivers program. And I love our Haitian staff so much. They've been doing an amazing job, even through COVID and even through all the unrest, getting these kits distributed throughout the Northern Department. And all the recipients have been really great for filling out their feedback so that we can measure the impact of these kits. And then the second project that we actually began also this year implementing was an equipment modernization and standardization program, where we're bringing in same equipment, standardizing for the region. For example, we've brought in over 90 patient monitors, all identical, that have gone into 7 different hospitals in the northern part of Haiti. They're all the same, that all the staffs have been trained on them. We're able to keep extra units in capacitation where they're close. We're able to keep parts, and then we also have the staff available to train and repair. So that kind of concept we're going to replicate on different pieces of equipment. And then we're also working with some other organizations on some grants to build in a biomedical training center to augment some of the programs that were already begun in Haiti. So I know about out of time, but I hope that this gives you a little overview of why we feel that data is important and how we collected the data, and then what we were able to do with the data once we had it. So thank you so much.
Great. Thank you, Barbara. And I've been impressed really with my years in Africa. When you can actually show data where the needs are, often it's much easier to find people who can step in and fill those needs. And so it's really about putting data to work. Our next speaker is Dr. Mwai Makoka. Mwai and I have known each other for quite a long time, both from Malawi. He looks a little more like the part than I do. He's a genuine Malawian. I'm an adopted Malawian. He's currently working as the executive for health and healing with the World Council of Churches in Geneva. He serves on the board of African Christian Health Association platform, CCIH, and the Ecumenical Pharmaceutical Network. Besides clinical practice, Dr. Makoka worked with the National HIV program and in academia, and previously was the director of the Christian Health Association in Malawi. So Mwai, thank you for joining us from Geneva, and we look forward to hearing from you.
Thank you very much, Perry, for the introduction, and also Barbara for your first presentation. And I will pick up from my colleague, Barbara, at slightly different angle, because the first presentation looked at more detail at a facility level information in a particular country. So I'm going to emphasize and present on a little more higher level. So I'm working with the World Council of Churches, and I'm making this introduction to see how the mapping project is sitting with the role and the mandate of the World Council of Churches. So the WCC has a convening role, and also seeks to provide room or create space for common voice, a common voice for our common witness, the mandate of the church, and to promote ecumenical cooperation. And we are looking at the healing ministry, the healthcare service delivery as a mission of the church. And we foster, promote coherence, cooperation, and joint witness, and having a common voice in the healing ministry of the church. Next slide, Kathy. And we wanted to create a common platform to share and engage and coordinate the health activities of the churches. And really, this is to promote our contribution to the Sustainable Development Goals. The SDGs, the catchword is leaving no one behind. And in terms of service delivery, we should also not be left behind, but we need to promote our contribution and see how to enhance that. And the plan was to have a phased approach, where the first phase, we collect information on networks at the country level, so country level networks. So data about organizations where Christian health associations, Christian health networks, whatever name they bear, and their mandate, the size, and the membership. And that after getting data at the network level, then we could go deeper to the membership to collect service delivery data, most of which, the type of which Barbara has presented, maybe to a lesser detail, but mostly service delivery data and population saved, range of services. So those would be in the second phase, but the first phase we thought would be wise to get information from the networks themselves. And we use the self-administered online questionnaire, which we developed jointly with the Christian Medical Association of India and the Christian Medical College of Vellore, India. And the questionnaire is translated into different languages: Spanish, French, Portuguese, and English. And we also did some online data mining to validate or to beef up the data that we were able to get from the responses to the questionnaires. Next slide. Okay, so now I'm going to share with you a few the key findings, what we got, and also the dashboard, which we felt would be a way to present it to the wider community. Next slide. Okay, so we were able to get 17 networks, 17 Christian health networks. They are distributed in 15 countries. You show them in the other slide, but we have 17, and out of these, they have over 7,000, close to 8,000 members within those 17 networks. And within them, together, they are over 1,400 hospitals, 2,321 health centers, and those clinics, and 483 training institutions running different programs. And some of the networks have individual membership. And so we see more than 10,000 individual members that are affiliated to these 17 networks. Next slide. Okay, so these are the ones we were able in the very first round of collecting this data. So we had Chad, Tanzania, Sierra Leone, Malawi, Bangladesh, Ghana, Zimbabwe, India, Liberia, Uganda, Togo, Great Britain, and Kenya, Lesotho, Zambia. And most of these we have, they were established in the 40s, 1950s, 1960s, some as late as the 2010s. We have had networks being established almost across, since the early 40s. Next slide. In terms of what's the organizational mandate, most of them, 18 of them say they actually coordinate, mostly coordination, support, advocate for church health institutions. I think some of the, okay, next, I didn't, okay. The other slide, I think there are some bullets they have gone missing, but most of them do the coordination, and the other group were actually fellowship. Okay, the 6 is fellowship, like prayer camps, devotional readings, and Bible studies, chaplaincy, and all that. And then the other 10, the other networks are actually providing procurement, food procurement, pharmaceuticals, and medical supplies. And then we have the other category with other functions. I think mostly we had examples of in-service training and other specialized training in addition, besides health worker trainings, like nursing schools and training in pharmacy and radiology and all that. Okay, next slide. So we had a lot of challenges to see how to present this data. And so we have in this map, the green are places where we have information, and then those we triangulated from online searches or from other sources, and we know there is a network, but we have not been able to get our questionnaire completed, and so that is in yellow. And then through our searches, we had no indication that a Christian health network exists in that particular country. So we have them in red. In some of them, we got a clear response that yes, we don't have any response. We don't have any network in our country. So we put those in red. Next slide. And those that are in green, then you can put your cursor there and get a few details that would be publicly available, which are the basic contacts, the institutional mandate, what the network does, and also the membership, how many hospitals, clinics that are there within that membership. Next slide. So in terms of moving forward, we really have not reached where we thought we could have been by now. The response is quite low. We have 15 networks. We know that there are establishments in many countries. So what we need is to turn as many of the yellows to green. And of course, at a later date, would those like to provide some support and accompaniment to those that are in red, where there are church hospitals, church nursing schools, and health worker facilities and activities going on, but there is no coordinated activities. There's no coordination, there's no cooperation. Maybe cooperation is only along denominational lines. Maybe they are only cooperating with their mother church or their church headquarters and their sister hospitals. So how to promote a common voice. So those to be supporting the reds to also establish a way of cooperation. But for now, I think to convert most of the yellows where there are networks, where there are networks, there are activities going on, there are church missions, but we don't have the data. So to convert those, it's after we have been able to get the national level data that we can confidently go down to collect facility level data. Because once we jump to facility level data, we can land into some challenges. in terms of confidentiality and also fraud and all that. We don't want people registering a hospital which doesn't exist, or claiming this hospital belongs to Church Y when it doesn't. So we can confidently do that if we get detail firstly at the national level, and we get a master health list at the national level. Then we can go down to health facility level to provide the service delivery, population saved, capacity, and all that for each of the health facilities. Now, really moving forward, we need a joint cooperation. When I started, it was very clear that this project is beyond one organization, even though, yes, World Council of Churches or CCIH, or, but it's beyond one organization. And we need all our efforts to pull towards our joint advocacy and our common voice, our common witness, beyond denominational lines, beyond geographical the geographical disparities that we have. So we need to leverage each other's networks. Some are like, we saw Cure is a network. There are hospitals in a number of countries. We need to bring them on board. We have organizations that train, equip medical missionaries. So they also have their own networks. We have some denomination-based health missions. Some churches have huge network of hospitals. I give example, the Presbyterian Church of Taiwan. They have a network of hospitals. And all that really, the end goal is to expedite health facility service delivery. The service delivery data, that's what is needed. Even now in the era of COVID, we need service delivery data, but we can't get to step 2 before we get done properly with step 1. And so we need to find ways of harmonizing our efforts. Those that are interested in mapping and those that may not be interested in mapping per se, but they can contribute technology or financial resources or human resource, or they have some capacity whatsoever to contribute, so that we can jointly move this and as quickly as possible have data that is useful to us within the church networks, but that we can also help advocacy and communication with governments, intergovernmental organizations, and other partners that are interested. Thank you very much. I'll stop there.
Great, thank you, Mwai. I think that's a very important point that you make, that really this is a task that's larger than any single organization can take on itself. First of all, we have overlapping networks, but also there are organizations that have access to people that other people don't even know. And just as I was preparing to host this, just in my relationship group, I learned that International Christian Medical Dental Association is working on a mapping project. MedSend is working on a mapping project. And so I think the important thing is to try to bring people together to be able to share data, but even just to share data about what maybe some tools and what are the data points that you can gather, because many of us are interested in learning different things. There's some people who may be only interested in what's happening in the evangelical component of what hospitals are doing, other ones that might be interested in teaching, people who want to know other things about the health system. So to try and decide what are the key things that we do measure. Barbara's, the Dalton Foundation is measuring a lot of site-specific needs, and then yours project is really, in a sense, measuring connectedness, that people have a network that they're utilizing. And so all of those are important things. And I think as we come together to try and create some common databases where we can have as much information as possible. And it's amazing when you have that information, it's much easier to see where the gaps are. And if you're providing information to donors, they look to CCIH and World Council of Churches and other networks to say, who are the people that are doing this kind of work? So it's a very important tool. I want to encourage those people who are from ICMDA or MedSend or other organizations interested in mapping to join the CCIH working group, Right now, you don't have to fly anywhere. It's all online. And we meet about every 2 months and share information about what's happening with certain mapping projects. So I would really encourage you to attend those, and you can find out how to do that through the CCIH website. And then there's a broader umbrella group on health system strengthening that's very valuable, and it's an opportunity to really bring people together to talk about how we strengthen health systems. We do have a few questions that I wanted to get to today. I think the first one I'm going to give to Mwai. I know a number of Christian ministries are working in countries that would be considered closed access countries, where identifying yourself as a Christian ministry and certainly as an evangelical ministry could put you at danger. What are your thoughts on how do we responsibly keep track of those and include them somehow without putting them at risk?
Thank you. That's very, very important consideration. And basically, that's one of the reasons you see that we have those that are in yellow. Okay, so those that are in yellow, some of them we know very well. We can enter the data for them. But we want them to volunteer the information. Okay, so if they are not happy, then they keep away from providing that information. So indeed, there are some that have contacted me to say, thank you, Mwai, we have received your request. We are happy for this work, but we are not going to provide you this information for our security reasons. So when you see us being quiet, it's not that we are not with you, but please understand our situation. So I've had, I think about 2 have contacted me and given me that those concerns.
Yeah.
Yes, so indeed,
I know.
for that reason, we want the health facility, the network, to fill in the questionnaire, even if we would put the data for them.
Yeah. So I think with data protection systems, there are ways that you can protect certain pieces of data, but it requires some trust in the who you give your information to. We had another question or comment sort of on these sites that are very busy doing work, and if they're approached by people that they've never heard wanting to map them, a lot of times that on the other end it feels potentially exploitative, and people don't know why they want this information. So maybe also to Mwai, what are the best strategies for trying to get data that without making people feel overwhelmed by so many people giving them data? How do you develop trust that the data will be appropriately used?
Yeah, in terms of the workload, indeed, this is a very difficult time to start any mapping project. So the information I have presented were not collected during COVID time. These were collected from late 2018 and 2019. Okay, so just to clear that. And again, there's rarely a point, yes, notwithstanding the pressure, the extra stress occasioned by COVID, but there is almost never a time where we say, yeah, now we have ample time on our hands, we're going to complete questionnaires. Okay, so the health work is always an issue of pressure. So what we need really is the leadership to understand the value of this type of work. And COVID has shown us that we need data beforehand. When the crisis strikes, it's not the best time to start looking for data. What data do we need? You don't know what type of crisis you are going to face. So when we talk about preparedness, yes, on one hand, we look at health preparedness in the normal traditional way. But as FBOs, our sense of preparedness also means having data. so that when a crisis strikes, you have some data that you can use to easily or more readily mobilize resources or reach out to partners. But that at that point in time, when you start now going to the grassroots, hunting for the data, it's too late.
Mm-hmm.
The other challenge which you mentioned in terms of that data sharing, yes, it's very clear. Exploitation, everybody's worried. What are they going to do with my data? And one of the reasons is actually the institutional mandate, the mandate of the one that is collecting the data. We have some that are collecting the data from a research point of view, academic institutions. So they have a set of limitation because they have a scientific interest. And so for the World Council of Churches, the health facilities are a ministry of the churches. And we are just promoting coherence and promoting our joint voice, our ecumenical cooperation, so that we may know where are the needs, if there are some resources, where are the gaps. That's part of our institutional mandate as WCC to promote ecumenical cooperation. So we are only convening. We don't have any interest as WCC to use this data, but really as a convener to collect this data and make it available to the ecumenical family.
Yeah.
So that now the family is enriched, we are able to know the needs that exist in the family, and we are also able to share, to cooperate, to liaise. So all these things, I feel that within the institutional mandate of the World Council of Churches, we are in a better position to ask for this data without being misunderstood in terms of the intentions behind the data collection that we're making.
Sure. And I think that's why it's important for organizations to be interconnected with larger mother body type organizations, because if everyone that's interested in doing health is going around doing their own independent surveys, it's a bit chaotic and people feel overburdened. So I think CCIH and World Council of Churches and ICMDA and CMDA are sort of convening organizations that are good places that do have that institutional mandate. A couple of questions for Barbara. One is just regarding this software platform that you showed. It looks beautiful. There was a question about whether that is available as a licensed product, or how would people get access to using that tool?
Yeah, thank you. Yes, it is available. Just as an example, we've morphed it into several other contexts already, and we have a few other projects that we're working on. So it can either be kind of licensed as is, or it can be morphed and adapted as needed for a different context. And then I would just like to add on to the previous question about the data collection. I think it's a really good point and a very sensitive topic for us. I think when we're gathering the data, I think it is a lot about relationships. We've been blessed with our Haitian staff. Our Haitian staff are the only ones that ever collect the data, and we always are working with the Ministry of Health. So we have that, I don't know if I'd say that authority, but sometimes that's a little bit of it. But it's about developing the relationships. Our main staff person has been in Haiti, obviously his whole life, but working in the health community. So a lot of people already knew him and his reputation. So that's been very helpful in our case. But it does happen where some people do not want to share their data, which is totally fine. We just note that in the work. I would say, as an example, it's about 2 to 3 out of 100 facilities where someone just doesn't want to share the data. And so we don't have it for those facilities, and we note that. We also do things, our staff will do things like setting up appointments, making sure we're trying to set a time that's convenient for them. And then, as Mwai so brilliantly mentioned, the understanding, having the leadership understanding the why behind it is really important. And then we also do hope to always come back in with programs that actually help support their work, because that's always our goal for the data, is how do we help understand what's going on so that we can bring in some solutions, some practical solutions to come alongside what they're doing. So I think that education on that is important.
Sure. When you go into a country that is a new country, do you initially developed a formal MOU with the Ministry of Health before doing site evaluations and data, or how do you, at what point do you engage them?
At the beginning. Ministry of Health has to be brought in at the very beginning. So in Haiti, we don't have formal MOUs. We have written agreements with the Ministry of Health directors in each department and also in Port-au-Prince. And then we don't have individual MOUs, obviously, going into each individual facility. However, when we get to that last phase of the way we work with the projects and the strategic planning, we do have MOUs with those facilities. So the ones we're bringing in the equipment to and things like that, we do have a MOU with them.
Mm-hmm. Yeah. I think it is critical when you're going in, especially as a new country, and if you're in a country for a while and you don't know the Ministry of Health people and you don't know the Christian Health Association people, you need to be interconnected. And even as, certainly as organizations going into a new country, that's a great place to start, because they have the network that you're looking for. And it can take some time, though, to build that trust, and they have to see that you bring some value to them. You're not just sort of a looky-loo that's there to exploit their data. Like you said, if people start seeing that you offering this data results in some resources that are flowing, people are a lot more interested in giving you that data. Let's see, we've got a couple other questions here. We've got just a few more minutes. So one of the questions I had, there's various different types of mapping. We have the geospatial mapping, like we saw with Mwai, that then you can drill down to maybe some specifics about the number of hospitals, and those are very useful. We saw with Barbara's that she had more sort of the organizational capacity mapping, what do they have in their sites? Does your site also, does your tool also include some of the basics of electricity and water, road accessibility, those kinds of things?
Great question. Yes and no. So yes, we do a lot with electricity, all kinds of detailed questions about duration of electricity, where they get it from, outages, things like that. If I was going to put up a phase 3 that we're talking about starting probably in 2021 or 2022 in Haiti, it would be to include things with water, but also add in a lot of the community health worker data, because currently we're not gathering that either, but that's another area of interest if we were going to go into phase 3. Okay.
Another tool that I came across was mapping the connectedness, and the World Council of Churches is measuring some aspect of that, but there are some tools that are available for mapping strengths of relationships, and we know that that networks are very powerful, especially when they're interconnected, that you can get ideas and resources and best practices to spread through a network. We learned that through COVID, that the more interconnectedness you are, the faster the virus or the information travels. And so that's another form of mapping that's very interesting. We had a couple of questions here about sort of the large international organizations like the World Health Organization and the World Bank and US government, and their attitude towards faith-based organizations. I know, Mwai, you're very connected with the international health organizations. Do you see any sort of trends within these larger donors and coordinating bodies in their attitude, their willingness to work with FBOs?
Yeah, thank you. I think the pandemic has highlighted several issues. And one of the issues is actually that health doesn't belong only to the Ministry of Health at a national level or WHO. Okay. It's not only health institutions. Everybody has a role to play. Everybody should be able to contribute, for better or for worse. And it's good if we are all contributing for the better. So, and to add, actually, even the interest within the church itself. Many churches have written health circulars, health pastoral letters. Many churches in this time of COVID. So the interest is not only outside the church family, even within the church family. And just to specifically talk about the multinationals and the intergovernmental agencies, their interest in FBOs is not that we are fulfilling a biblical mandate on health. Their interest is on service delivery. What are you doing? How many people are you serving? What can you do? And what can't you do? So it's really, that's the value they see. So if we say, yeah, we can do this and we can do it better, that's fine. So we need to talk the language that they understand. And the language that they understand is the language of data, is the language of service delivery, is the language of population saved, bed capacity, challenges and situations that we are facing. So that's the language. And the earlier you can provide credible data, the better it is, and the more value you have. And the more likely you are going to be taken seriously, and also the more likely that you can get the support that you need. So when you're on the ground, it's very difficult to see sending this data into the unknown, whether it will bring anything valuable. While someone is trying to say, okay, yeah, but at the national level, what can we do? And we find that even though we have a very big potential at the ground level, that potential is not fully utilized because we are not able to talk the language that WHO and the other World Bank, UNICEF, that's the language. If we're not able to talk the language that they talk, we're not communicating.
Yeah, I think if you go into these sites, whether it's a clinic or a hospital, they almost always have data on how many patients they saw, how many admissions they have. But often that data is sitting in a register on a dusty desk and nobody looks at it, except maybe, they might do a year-end or year-to-year comparison to have ways of channeling that data into a common database that can do some filtering by who they are, where they are. So sharing data. So data exists, and I like the description of translating data to information, to knowledge, to wisdom. And so those little data pieces, like how many patients you saw, if they're combined into what proportion of the healthcare do Christian health associations provide within a country, that's really a valuable information that can lead to a greater knowledge of how to impact health. And so it starts with the data, but it's what you do with that data, turning that data into something that is usable, combinable, and something that we can translate into some greater understanding of how the health system works, what the health of a country is. And so sharing data is a huge part of that. We had one other question on just some details, Barbara, on how people would get access to the tool that you have.
So it depends. So again, to use the public facing piece of it, it's just, go to www.reallyGlobalHealth.org, and then you'll see a link to that page that I showed. To probably what more people are asking though is how could we have access to use that database like for our data? And that would be just to contact us. And again, the email is on that website, but it's just info@reallyGlobalHealth.org. And then either me or someone on our staff would contact you about, kind of what the project is, just learn about the project and see how the tool could support. because for us, like entering the data and all that is not always our passion. We want to share the tool with others to let them use it in their work. We don't want to actually do all the work in all the countries. We want to be able to just share the tool and then let others do that. So that's definitely the goal. So
and I think there are people
contact
who would like to do a better job collecting data, but they don't actually have the tools. And I think sort of to that end, I would encourage people to stay connected. I think CCH is a great place to get that information and stay connected. We've got this health systems working group, and we've had some discussions about tools. AMH has developed an organizational capacity assessment tool that's specifically designed for mission hospitals. But to make these people aware of these tools and make them accessible, I think it requires being connected. And that's the great thing about CCH is that it has a broad reach. And so we've got people here from all over, actually. We've got a list of countries here: Zimbabwe, Nigeria, Kenya, Haiti, Uganda, India, United States, and several others. And so we're preaching to the group of people that are out there doing the work. And so we understand it's hard when you're busy to stay interconnected. CCH is one of those places with fairly low quote cost. there's no cost to going on the website, some small cost of being a member, but it's a great convening organization that's really bringing people together, not just who are evangelicals in the southeast of the United States, but is something that's broad and it's global. So I would encourage you that it's a good use of your time to come together at CCIH, participate in their webinars. If you can, become a member, but there's lots of great videos, a lot of information, and you can participate even in working groups while you're kind of feeling out whether this is the right place to be a member. And I encourage you to contact CCIH and become a member of this health systems working group. If you're on this call, it's because you have some interest in health systems and in mapping. So we'd encourage you to just let CCIH know. You can contact each of us individually. We covered, I think, all of the questions that were on here, but if you have more questions, please send those on to CCIH and then we can answer those individually. I want to thank you for your time, and thank you, Barbara and Mwai and Stuart for being here, and for CCH for hosting us. And I hope you all have a great day, and we appreciate you joining us.
Thank you very much, Perry.
Thank you, Perry.
Sure.
Thanks, everyone. Bye.